There will be a question like that on the exam about proper directions for taking antibiotics, whether they can start without food, which they should, um, and in particular, if there are certain medications that suggest that certain food should be avoided, even if you are taking it with food. Expect symptoms up to 48 hours. So that's kind of right, Natalie. For the 48 hours is the fever. So we would expect they might still have symptoms. You know, if someone is taking antibiotic because they have bacterial pneumonia, in 48 hours, I would expect them to no longer be spiking fevers, but they probably still will have symptoms of the pneumonia. So the 48 hours is fever. The one that has to do with symptoms is if the person still has symptoms when the course is completed, then we know there's a problem. Can anyone think of anything else? Right, so and there's definitely some side effects, but this is just administration, so we will go to that in just a second. So yes, Aisha, we want them to increase their fluid intake. Right, so that'll be more of the side effect thing. So when we, for if in case you're not seeing what I'm talking about, Sharita said it can affect birth control strength, which is true. But if we're just talking about rules of administration, we want to be sure that the patient tries to take it on an empty stomach, but can if they, right, thank you, Lillian, can if they can't tolerate it, should increase their fluid intake and then decrease things that cause dehydration, like alcohol. Um, there's the 48 hours with fever. Yes, that's correct, Nelly. So there's the 48 hours with fever. There's the no symptoms after completion. Take it as directed and do not stop when you feel better. Those are all administration things. So this is sometimes, I don't know that I would have something this particular on a nursing exam, but this is sometimes why people get things wrong on nursing exams, because you are all giving me correct information about antibiotics, but not necessarily the information that I'm asking. Because I am just asking about the rules of taking it, not expected side and adverse effects with all antibiotics. That's two different things, and that's sometimes why people get things wrong. Like I noticed in the cardiovascular exam when I was going over people's answers, you know, like there's one, I don't remember the exact wording, but it's something about nitroglycerin, and it's supposed to get you to focus on telemetry and frequent blood pressures because that's the rule with nitroglycerin administration. The other things, one is frequent temperatures to rule out malignant hyperthermia, but that's not a thing with nitroglycerin, that's lidocaine. And the other one was be sure the head of the bed is up by 45 degrees to prevent aspiration. So sometimes people pick that, right? Because you're obviously we don't want people to aspirate, but nitroglycerin doesn't cause vomiting. That's not like the issue with nitroglycerin itself. So you sometimes get thrown because you're picking things that are good, but not necessarily directed at the medication that the question is asking. So always kind of focus on that. That's sometimes why people get things wrong. And then when they talk to me about it, I'm like, oh, that's really sad because they actually know the information. So all the things that we're talking about are actually on these slides. It's just a way to keep practicing it. Sometimes it's helpful if you practice things and write them and rewrite them. That was on, oh yeah, that was on the slides about infections. Where are you? Too many things going on. If you look about those slides about infections, the ones for studying for this one, Common directions. These are those common directions. Usually best with food, but if you can't, you can try it. Fluid intake, no alcohol, take as prescribed, call if fever after 48 hours, call if symptoms persist after completion. So that's all that information. But it'd be good to test yourself and see if you can remember. The other one, the other thing that I put on the study sheet, but that's also on this um, material, is general side and adverse effects, which some of you were mentioning. So allergy is one, um, GI distress of some kind, nausea, vomiting, and soft stool, stool that is the consistency of soft serve ice cream, not watery. And then those super infections or secondary infections or supra infections, those are all the same. C. diff and fungal infections. That was all on that slide too. And then this sheet, which I will also upload, the other question, see if you remember, this was, does anyone remember some of the general information about IV antibiotics? Some of the things that are special about IV antibiotics that were kind of common. Right, so painful. So and it can cause what's called thrombophlebitis, which is inflammation um, where the IV is, and that might be like streaking. It might feel like it's burning. The way we get around that is hopefully the medication is diluted correctly by the pharmacist, and we're giving it at a rate that is slower. Again, determined by the pharmacist, but that's why, because we're trying to prevent that. Excuse me. The other issue is that there are multiple IV incompatibilities. So anytime you're giving an IV antibiotic, you have to be sure that it's compatible with the other things that the patient is receiving IV, so there isn't a problem. And because antibiotics are by far the largest group of medications, you could organize them like this. Like these are antibiotics that alter the bacterial cell wall, and then these were the families of antibiotics that altered bacterial cell wall, but then each of these families had a prototype. Does anyone remember what amoxicillin's prototype medicine was? Like the type of penicillin you'll see on the exam? Augmentin, Natalie, is one of them, but on the exam it'll be amoxicillin clavulanic acid because we always go by the generic names, and the other is just, yep, amoxiclav. The other is just plain amoxicillin. So those are the ones that you'll see on the exam. Oops. What about the cephalosporins? What was our Keflex? Aisha, you're correct. So it's all medications that begin with CEF, are cephalosporins. Ours was cephalaxin, which I think is what Kelsey is spelling, which is Keflex, and cefotetan, which is the one that has the extra bleeding side effects and the one that's used for meningitis. That's correct. What about our prototype? Well, they're hard to spell. As long as I can kind of figure it out, we're good. What about the prototype for monobactams? This is one of those IV ones that we have to worry about. Azactam. That is correct. So it's a more narrow spectrum antibiotic and more of a use for more serious infections. carbapenem, that family is also one used for more serious infections. Sharita, don't worry. I can kind of figure out what you mean, so that's all that matters. So carbapenems was imipenem, and vancomycin is vancomycin. So it's always good to be sure you know the medication names, because that will definitely mess you up on the exam if you don't recognize the names at all. So then we had antibiotics that inhibited protein synthesis, and those three families were tetracyclines, macrolides, and aminoglycosides. And then tetracycline was doxycycline, and macrolides was azithromycin, and aminoglycosides is gentamicin. Antibiotics that inhibit DNA synthesis is fluoroquinolones, and that's ciprofloxacin. And antibiotics that inhibit folic acid are sulfonamides, which is sulfasalazole and trimethoprim together. So that might be a way to organize things, and then so you could put the prototype medications on one line, and then maybe some special things about each medication that's different from the general stuff on another line. It might be a nice way to organize it. So I'll um, upload that for you guys to see if that's helpful. Any kind of different ways you can try to present the information to yourself can sometimes be helpful. Um, so that's that. So we're at the point of a break. So we will take a break from 9:45 to 9:55, and then we will start on finish out the medications for infection, for fungal infections and viral infections. So I'm gonna, okay, we are back. So right now, where we will continue is with medications for fungus and for viral infections. Those were the last, um, that was the last group of medications for infection that we need to cover. So I'm going to share my screen again, and we are recording again. Okay, let me get rid of this one. So fungal infections, that is a picture of a fungal infection under the microscope. It typically looks like spaghetti and meatball pattern is what people say. Fungal infections, they are, fungus are obviously alive. They're eating dead tissue. They're usually, they can be in the soil, air, and water. They're usually transmitted through spores and can infect people through openings in their skin or by breathing them in. Fungal infections can be pretty serious. They can, they could just be a superficial fungal infection, like one might have, um, like a tinea or a yeast infection. Um, the official name, like for ringworm, is a tinea infection. It's not really a worm; it just looks like that circular shape. Or a vaginal yeast infection, oral yeast infection, anywhere on the body. Versus there's fungus in your bowels. So if you had a bowel perforation, you could have a serious systemic fungal infection. There's a fungus that people sometimes breathe in, and you can develop a horrible fungal pneumonia infection. So there are medicines for fungus that are available either to give topically or to ingest as a pill or to give IV. It depends on the type of fungal infection and how severe it is. So all of these antifungal medications work by breaking holes in the walls of the fungus, and that way it can destroy the fungus. There are two groups of antifungal medications. One are called polyene antibiotics, which is unfortunate because it makes it sound like it's for bacteria, and it isn't. And the other are a group of antifungals called azoles. In the polyene group, amphotericin B is the one that you'll see on the exam. Nystatin is another example, which can be found over the counter. It might be something that you've heard of before. So nystatin can be given topically for certain types of infections. Amphotericin B is a medication that's given for severe systemic fungal infections, or like that fungal pneumonia we were talking about. This is a very difficult medication for a person, however, to get. So the person who is getting this medicine is very sick already, and then to have this medication, they might start to feel sicker until they get better. This is an IV medication, so again, we have to worry about thrombophlebitis and multiple IV incompatibilities. The body reacts to getting this medicine, so people need to be pre-treated with Benadryl to block any histamine reaction, and acetaminophen or Tylenol to block any fever reaction. Once you're giving the medication, after an hour, the patient might experience fevers and chills and headache, nausea, hypotension. So this medication is generally given to a patient that's in the ICU because they need a lot of monitoring. In terms of toxicities, we have to worry about bone marrow suppression and renal toxicity. So which types of cells are produced in the bone marrow? White and red and platelets. That was the one I was looking for. So and leukocytes are white blood cells, red blood cells. So we'd have to worry about people getting anemic. If their white blood cell count gets really low, that would be bad in this situation because we're trying to get them over an infection. And then if their platelets are low, they might be at risk for easier bleeding. However, anemia is the worst, is the most possible. And then the other possibility is renal toxicity. So, what is the blood test we would check if we're worried about kidney dysfunction? BUN is part of it. And creatinine. So that's the sometimes called the basic metabolic panel. That's the blood test that will have the kidney function, and the BUN and creatinine are very sensitive to that. What kind of symptoms will the patient have if they're experiencing trouble with their kidneys? Edema, right. Fluid retention. Exactly. Not the jaundice, because that's with the liver. So this is if correct, it could be if the fluid is getting trapped in their lungs. So if the kidneys aren't working, then we're not filtering fluid as well, which is why we'll have fluid retention, like Lillian said. And then we could see the fluid other places in our body. It could be in our legs or it could be in our lungs. So, what piece of physical exam information is the most sensitive to weight change? Oh, I just gave the answer. If we want to know if someone's retaining fluid, their weight is the most sensitive indicator. Um, right. So then we know this person who's getting this medication will, like I said, be in the ICU and be monitored very closely. But that's the things they're going to look for changes in their weight and fluid retention. The other class of families in the um, antifungal medication is azoles, which can treat candida yeast or tinea infections. So candida or candida infections and yeast infections are treated with those polyene medicines, but they don't do well for tinea, which is the kind of different sort of yeast infections on the skin. The prototype for us is ketoconazole, even though that's not really prescribed as much anymore. You probably may have seen fluconazole prescribed more, which is also referred to as diflucan. That's its brand name. But ATI talks about ketoconazole, so we'll put that as the medication that we're focusing on. This is a medication that could be given topical, it could be given by mouth or IV, same as fluconazole. It depends on how severe or deep the infection is. If it's just a surface skin infection, I could apply the medication topically. If it's just, maybe a little bit into the deeper layers of the skin, or I'm having a hard time getting rid of it, or it is been a while and I've been on IV antifungals and I'm switching to PO antifungal, that's also possible, or it can be given for some of those serious fungal infections. This medication has some weird administration directions. It should be given PO separated from antacids, but given with carbonated beverages if possible, because that carbonation enhances absorption. When you apply the topical treatment, the patient might notice some like burning or tingling at first. If you're giving oral ketoconazole or IV ketoconazole, they might experience drowsy and dizziness, same GI symptoms we've always talked about, and potential hepatotoxicity. So Sierra kind of started us down that road with talking about things that happen when your liver isn't functioning. So jaundice is definitely one of those symptoms. What else? Right, the dark urine, pale stools, because the bilirubin is then leaving through other ways out of your body. So sometimes people have abdominal bloating or pain, and then they're not going to handle the bilirubin correctly. So what blood test will we check if we suspected the patient had a problem? Anyone know? No, that's the kidney. LFTs, that's correct. Liver function tests. Specifically, the part of the liver function tests that we are concerned with is, I'm just seeing what people are typing, right, ALT, AST, yep. So those are particular liver enzymes that are specific to the liver. So the ones that will for sure tell it's an acute problem is ALT, AST, and bilirubin. The albumin will change over time, but much, much later, Natalie. It will be the liver is in charge of helping to create that protein, but we won't notice a change in albumin until the liver is very diseased. So it would be the liver enzymes that we would be looking at first. All right, so those are our two antifungal medications. And then the last group of medications for infection are medications for viruses. So viruses are much, much harder to treat, even though they're very, very simple structures. They're much simpler than bacteria, certainly way simpler than fungus and parasites. However, viruses are tricky because they are considered an intracellular parasite. The way they divide, the way they take over is to go inside a human host cell and kind of take over that cell so that it only produces the virus. So let me kind of explain that a little bit with the picture. If this is my human cell, wherever it is that the virus is deciding to infect, could be my respiratory system or whatever, that human cell has its own DNA and it's ready to take care of its own needs. The virus will just be a piece of genetic material. It could be DNA, it could be RNA, and this piece of genetic material, yeah, this piece of genetic material is wrapped in some kind of protein to sort of protect it. There doesn't have to be, there's not much material there at all. If this can match the surface proteins of our cells, then it can attach. And then when it attaches, it's able to go inside the cell. And once inside the cell, it can kind of splice our DNA and insert itself into our DNA. And then our cell no longer becomes our own, really. It just becomes a factory for new viruses that then are able to bud off and go infect other cells. So you can see the problem with these other medications. We're with all these infections, we're creating medications that attack an outside structure much easier than it is to attack a thing that's inside of our cells, because we can then damage our own self. So it's very hard, much harder to get good medications for virus infections. So there are antiviral medications. Certainly the best treatment for viruses, if it is available, is a vaccine, because then you sort of get your own immune system ready to deal with the virus. And then if you get infected, you either don't have symptoms at all, or you have very mild symptoms. You can use antiviral medications as a treatment, but it doesn't always do so much. You have to be sure that you treat it as fast as possible. And what you're hoping for is that the virus, the infection is shorter or not as severe. A lot of times people can also take antiviral medications as prophylaxis, meaning if they've been exposed to a viral, so someone with a viral infection, they could try to take an antiviral medicine to stop it from being a problem for them. So one example of a viral infection that is, of course, all over the place is herpes. My microbiology teacher in undergrad said that love is forever, but I'm sorry. Love is fleeting, but herpes is forever. I destroyed that punchline. So anyway, herpes infections can be what are sometimes termed as herpes simplex 1 and herpes simplex 2. Sometimes considered oral herpes versus genital herpes, though there is switching in between. Just because you have a herpes sore on the mouth doesn't mean it's herpes simplex 1. It could be herpes simplex 2. It's everywhere. It has a very long incubation period, so it can be very hard to tell people, like, you got this, which partner gave it to you, because the incubation period can be 5 to 10 years. So if you get an acute herpes infection, you can take a medication called acyclovir, which is an antiviral medicine for herpes. You can take it as a PO medication, an IV medication, or a topical medication. If you're using it even for yourself topically, then you should use gloves. I mean, that's good practice for anyone. Anyway, certainly if a patient had a rash, you wouldn't be applying a cream to them without gloves. But the definite worry with herpes infections is that you can actually inoculate yourself with herpes in a different area. So maybe I was treating my lips topically with acyclovir, and then, I touched some other part of my body that there was some skin breakdown, and then I could give myself a herpes infection someplace else in my body. So if you're taking this medication PO, acyclovir PO, there's really no side effects. The problem is you have to take it around the clock because it's 5 times a day. So compliance is very difficult. There is, although that's not our prototype drug, there is a different medication called valcyclovir, which allows for twice a day dosing during acute infections, which is nice. If the person has a systemic herpes infection, you can get this medicine IV, but then there's a little more danger to it. It's an IV medicine, so that means there's multiple incompatibilities, and you have to worry about thrombophlebitis. But um, you also have to worry about protecting your kidneys, so they have to usually be on IV fluids or with good hydration, and neurotoxicities like paresthesias, where you have numbness and tingling or seizures. It is a vesicant, which means it could burn the tissue around if it came out of the IV. So sometimes um, people will take acyclovir or valcyclovir as a preventative. Maybe they have a history of genital herpes, and in order to suppress outbreaks, they could take a smaller dose every day to try to reduce the transmission to their partner, which is very effective. Otherwise, it's best to treat a new infection within the first 24 to 48 hours. So sometimes, if I don't know if anyone has cold sores, which is essentially what herpes infection of the mouth is, you will get like a tingling sensation first. It's actually best to start treating then. You're more likely to shorten the course than if you wait for time to pass. And the person with the tingly lips actually is infectious. They could give it to somebody else. So that might be the best time to treat it. Another antiviral medication, this is Tamiflu, oseltamivir. It's very hard to say that, but that's the medication for influenza. It can be given as a prophylaxis only if you have close contact with somebody that's had influenza. So, like you live with a person, there's a couple and the partner had influenza, you might treat the other non-ill partner just because they were so close in contact. It's very possible that the person will get influenza if they haven't been vaccinated. It can also be used as a treatment for influenza, but again, if it's an active infection, the treatment is only um, decreasing the time of the infection or decreasing the severity of symptoms. That's the best we can hope for. And it must be given within 48 hours of symptoms, or it won't have any benefit for the person at all. The adverse effects we have to worry about are neurologic. The person can actually develop psychosis and Stevens-Johnson syndrome. So, what's Stevens-Johnson syndrome again? Oh, I know you guys confuse that on the exam too. That's toxic epidermal necrosis. Oop. So it is one of those delayed weird skin things. Yes, Kelsey, it's the blistering. So the person has taking a medication. So this person in this scenario would have had influenza and they started taking Tamiflu in order to get rid of the influenza symptoms. Um, so then the person will start to feel kind of sick again, like a sore throat, weird feeling like that, and then they'll develop a blister type rash to the chest and torso, which then can become more severe. It kind of grows together, and the chest and body can get really red. So they're similar. Like if you looked at a picture of Stevens-Johnson syndrome and a picture of toxic epidermal necrosis, it might be hard to tell the difference in the picture because they're both very red, angry looking skin. But the key is the person with toxic epidermal necrosis, their skin can peel off, and the person with Stevens-Johnson syndrome has the blisters, and the first complaint is URI symptoms, the upper respiratory infection symptoms. So be sure. It feels to me like a test question that I might do, like patient is on Alcetlomivir, which is Tamiflu, and they have been taking the medication, and suddenly they have like a sore throat and start getting blisters. And the questions could be, what should they do? Versus questions could be, what is it? So just be sure you have that straight. Right, and that would be the answer. The patient should call the provider. They will have to, they eventually will probably have to stop that medicine and they may need to be admitted to the hospital. So as we go through, I just want to be sure that because not everyone has checked in. As I look through my attendance list, I don't see that Cassie checked in or Marissa did. So please if you're here, please say so that you get credit. Sharita, I got you down. And I have you down, Caitlin. The only two that I don't have down right now is Marissa and Cassie. Everyone else I have. And I do have you, Devin. I'm not going to talk bad about you. Okay. No, I have everyone. I have everybody but Marissa and Cassie. Yeah, is Devin really here, or is he just faking it? So if Marissa and Cassie out there, you better say something. Okay, so the last group of viral medicines we have to talk about before we take our break has to do with the treatment of HIV. So there are many medications and many developments in how to treat HIV. It certainly has changed a lot since, yes, and it's recorded. If it's recorded, your busting is recorded. Okay, so the HIV in particular infects part of our immune system, an essential part of our immune system, which is the T helper cell. That T helper cell turns on the entire adaptive response. So to have not enough functioning T helper cells puts the patient at risk for many, many infections that they wouldn't normally get because a healthy immune system, they wouldn't get them. So HIV itself is usually, it has a long incubation period. So the person could be exposed to it and may have like a couple symptoms, like they have just any kind of virus, or they might really not have any symptoms at all. And that incubation period can last years, but the person could still be passing HIV on, which was, of course, the problem. No, Aisha, wasn't you. Which is the problem in the 80s, especially because people were getting infected quite a bit. So the person isn't actually going to feel like they have HIV until their viral load or the amount of HIV in their bloodstream is at a certain level that it's really cut down the CD4 or those helper T cells down, that they can't fight off any normal exposure. And then they can get a disease that might meet AIDS criteria, which is acquired immune deficiency syndrome. That is not really a separate infection. It's just the end of HIV. If you completely destroy your immune system, you end up getting an infection that will eventually kill you. So you have to be on lifelong treatment, and there is very successful drug programs which are much easier to tolerate than they were, but they're still hard. Still, usually a 2 to 3 drug regimen for the rest of your life. And just like with tuberculosis, if you see this on the exam, the reason you take more than one drug when treating HIV is to prevent resistance, because that is the problem with all things. The minute you stop the medicine, the types of virus that survive are the ones that have adjusted to life with the medicine. And then it can be harder to treat. So if you lapse in your treatment for a while, you might develop viral resistance, and then the drugs that you used before will no longer work. So they're on multi-drug regimens, just like the people with tuberculosis had to be, with active tuberculosis, had to be on 2 medications. We have to do that same kind of thing. So the medication is meant to target the steps that HIV takes in order to divide. So the one that will be on our exam is the first one, which is zidovudine, which formerly had been called AZT, which was the first HIV medication to be developed. However, there is, um, as you can see, many other types of drugs available for HIV. So HIV is an RNA virus. So when HIV comes into, so first it has to attach to the cell, then it has to gain entry, and then once it's inside, it has to, what it means to be a retrovirus means it has to back translate itself. Because usually RNA translates, DNA translates to RNA. So now RNA has to translate to DNA, and then it has to splice our DNA and integrate itself, and then it has to let then more of the HIV virus buds off and leaves the cell. So these prevent that reverse transcription where it says RTI and NNRTI. Those are medications that are preventing reverse transcription. So the virus can get inside the cell, but if it can't transcribe itself into DNA, then it can never get into our DNA to reproduce. This one, raltegravir, is an integrase inhibitor. That means that we could reverse transcriptase, we could splice the gene, but we can't get ourselves inside, the HIV can't get itself into the DNA. Protease inhibitors prevent splicing the gene. These medications are usually reserved for people that have developed resistance. They prevent fusion and uptake of the virus to begin with. So we're trying to target all the steps that the virus takes. So we are non-reverse transcriptase inhibition. So we're not allowing that reverse transcriptase to take place. Zidovudine is our prototype medication, which used to be referred to as AZT. It is an oral or IV medication. One of the things that is good about zidovudine is that it can help prevent transmission from a mother to her unborn child. And that's if the mom finds out that she has HIV, she can take oral zidovudine as a prevention to try to prevent the transmission of the virus to her unborn child. And then at the time of delivery, she should be given IV zidovudine to help prevent transmission during the messy delivery. So the issue is there's a lot of side and adverse effects. So they can have muscle aches and fever, GI side effects, CNS side effects, which means potential paresthesias and seizures. And then it can cause bone marrow suppression, especially the red blood cells. The patient can become very, very anemic. So all of these medications are hard on the body. They're not the easiest medications to take, but then they prevent HIV from becoming AIDS. So here we are, a little tiny bit ahead, but not too much. We will take our next break till 10:40, and at that time, when we restart at 10:40, we're going to start talking about the immune system and immunostimulants. That's what we'll talk about until lunchtime. Does anyone have any questions before we take our next break? I will never step away from my computer because I don't want to get busted. Nope. Okay, so I'll see you guys at 10:40. I am coming off the call. sure we are unpaused and sharing. I hope they're okay. Been in there for a little bit. All right. Isn't that what Devin said? Pretty sure that's what Devin said last. He was in the bathroom or something. Um, okay, immune medication. So the immune system, of course, is part of our body that helps us fight infections. There are several layers to our immune system. There's the innate immune system, which is trying to protect our body from invasion to begin with. So that would include all the barriers that our body has, like skin barriers. It would include um, the inflammatory process or the immature white blood cells, all those things that help and prevent infections to begin with. But then if we do get an infection and then we turn on the acquired or adaptive part of the immune system, which is the specific, more targeted immune system. So the end stage of that is if here's our innate immune system, it's kind of the tie-in there. If right here, we have what are called presenting cells that can tell those T helper cells that we were talking about that there's an infection, and the end point of our adaptive immune system, especially important to us, is antibodies. There are other parts to it. There are cytotoxic T cells that also assist with it, but we have to make antibodies to help our body fight viral and bacterial infections. Obviously, medications are needed for bacterial infections, but we can pretty well get rid of viral infections. We do a pretty good job, with the common cold and things like that with our antibodies. So this is a key concept to understand active versus passive immunity, because this is part of the basis of the medication. So if my body is creating the antibodies, then it's active immunity if my body does it. If it's passive immunity, then I'm given the antibodies. So active, I have to do the work in order to get the antibodies. Passive is I'm just given the antibodies without having to make them. So I didn't have to do any exercise. How I kind of exercise is active. If I'm sitting on the couch, I'm passive. Actively, I have to make the antibodies. Passively, I'm given the antibodies. There's a natural way that occurs for everybody. I can receive, naturally, I could receive, or I could make antibodies by actually getting an infection. So if my body is exposed to an infection, then I will go through this whole immune cascade, and eventually my body will create antibodies to fight that infection. I could passively get antibodies from my mom crossing the placenta or through breast milk, and that way I didn't have to make them, but I do get protection from many of the infections that my mom has been exposed to. So the baby doesn't make the antibodies, they're just given to them. That's natural. But we can use medications in the same way. So I can give somebody a medication to stimulate them to make antibodies. And that's vaccines. The purpose of a vaccine is to expose the body's immune system to material that is similar to an infection, so that antibodies are created. That if I get the infection again, if I'm exposed to it, I won't have symptoms. Passively, I could give somebody immunoglobulin so they don't have to make it by giving them a bag of immunoglobulin. Those That's the passive immunity. I just gave them antibodies. Those are the two medications that we're going to talk about that are an example of immune stimulant medicines. So I'm activating the immune response. I'm augmenting the immune response. I'm helping the person's immune response be better. And I can either do that by making the person create antibodies in preparation for an infection, or I can give them antibodies because they've been exposed to an infection. I don't have time for them to make the antibodies. So this is very important. Active immunity means the body is creating the antibodies, and the medicine that falls into this category is the vaccine. Passive immunity means the body is given the antibodies, and the medication that falls into this category is immunoglobulin. Hard to spell. So that is considered stimulant to my immune system. Really, I'm creating a better immune response is a better way to say it. The last medication in the immunostimulant category manipulates something called interferon. Interferon is a messenger between cells of the immune system. So if I add interferon, I can help the immune system work better. So those are our three categories of immunostimulants, and the medications you might see are what are listed on that slide, and those are types of vaccines, MMR, which is measles, mumps, rubella, hepatitis B, and Gardasil, which is for HPV. Immunoglobulin, Hep B immunoglobulin is for hepatitis B infection, and interferon alpha 2A, is also a way to treat hepatitis B. So vaccines are our first thing to discuss. Vaccines are an example of artificially acquired adaptive immunity, meaning we are giving somebody the ability to create antibodies by giving them information about infections. And these vaccines can come in many different ways. The two that we are talking about is live attenuated or recombinant. So recombinant means that there is DNA modification of an infection so that it's close enough to the infection without giving us symptoms, without giving us the disease. So it's enough to stimulate the immune system to create the antibodies we need. Attenuated or live attenuated means that there is infection present, but it's dampened somewhat. So as long as the patient has a healthy immune system, they will not get the infection. So the example of a live attenuated vaccine we have is MMR. An example of the recombinant vaccine is the HPV vaccine Gardasil, or the hepatitis B vaccine, which is also recombinant, meaning that you cannot get the active infection from it. The other one is influenza. So you might even think this yourself, I don't know, but there are a lot of people that believe you can get the influenza virus from the influenza vaccine. The shot is a recombinant vaccine, so you cannot get an active infection from it. It's possible if you take flu mist, which is a live attenuated vaccine, instead of giving the injection, that it's like a nasal mist. It's possible that you could, if you did not have a healthy immune system, get influenza from that, but not from the shot. So what's happening with these vaccines is that you're introducing the body. Oh, go ahead.
Is it true that if you already have flu symptoms and they give you the influenza shot, you can like get influenza?
No, If you have influenza and you get the influenza shot, sometimes that helps augment the immune response. Um, you cannot get influenza from the influenza shot because it isn't the same thing. It's genetically modified. You sometimes people will get, and what the confusion comes in for patients and maybe yourself is that you can sometimes get symptoms after any vaccine. You know how when little kids get vaccines, they can get a low grade fever, they can get achy and whiny. So you can get symptoms like that after any vaccine. And so people will say, "Oh, I got influenza vaccine and I got sick."
Yeah, why is that? Why do you get that? Is that because your body is spending all this energy trying to kind of react to it?
No, it is because that when your body's immune system is revved up, that's one of the byproducts of it. So it actually means it's working. Because that it just means that my immune response is working. So when I'm creating antibodies, I have to send messages between immune cells, and those immune cells can raise the temperature and can cause some, low lying inflammation, so I can feel sore and kind of sick. So that if people don't feel well after the influenza vaccine, it's because their immune system is revved up. Um,
Okay, now I know. Yeah, because my children and I, whenever we get the flu vaccine, we always feel kind of ugh.
yes, and that can be with really any vaccine. That's possible to have that feeling. Influenza seems to have that reaction. Um, not everybody gets it, but some people certainly do. Any vaccine can cause that reaction because that's just the byproduct of the immune cells working. Another question that people often ask about vaccines is what are the long term effects of this vaccine? And I think that question is based on a misunderstanding of what vaccines are and what the immune system does. And it is confusing, especially if you don't know a lot about how the immune system works. Is when I get the vaccine, the medication that's in that vial that's injected into me is not going to stay in my body for the rest of my life. It's only going to be there long enough um, as my body creates an immune response. Then that medication is gone. What I'm left with is a file folder almost of how to deal with this infection if I ever came in contact with it again. Because the good thing about the immune system is it's sort of primed or specialized for second exposure. If I'm ever get an infection, what I'm hoping for, and for a lot of infections, is retained immunity. If I get the infection and my body clears it, and I have like a file folder of antibodies that know how to take care of this infection, then if I'm ever exposed to it again in the community, because it's still there, then my body will attack it so fast and so furious because it already knows the directions, doesn't have to build anything, it's all ready to go, that I'll never know that I was even exposed to it again. And that's the whole point of the vaccines, is to prime someone's immune system so that if they're ever exposed to the actual infection, the immune system's response will be so huge the person will never know that they could have had this other illness. So that medicine, whatever genetically modified thing was injected into your body, that's gone. You're just left with the immune response. And I think that's part of people's fears is like, well, what is the long term effect of this medication? Well, the medication's gone. Um, the long term effect is that you don't get an active infection. So the problem with influenza is that it is a frequent mutator. So influenza has several proteins on it. There's proteins that allow entry into the cells, and there are proteins that allow exit out of our body cell that was hijacked. And those proteins can mutate. Those proteins mutate easily, And each year there might be a slight drift, or they might go back and forth, um, or there can be a dramatic shift in the proteins, which make it harder to take care of. And that was the basis of what people call the Spanish flu, except that it didn't originate in Spain. It originated in the U.S. In a farm in Kansas. But interesting side note: the only reason why people call it the Spanish flu is at that time in Spain was the only truly free press, because a lot of countries were trying to downplay the idea that there was a flu going on at the same time as World War I, because everyone was feeling hopeless. So that's why it's called the Spanish flu. It actually originated in the U.S. Um, and the other issue is that you don't retain immunity as long as you would like. So you could have been immunized against one strain of influenza, and the flu shot helped you for the next 2 or 3 years, but then the immunity doesn't last. So, like, I'm sure when you started nursing school or were about to go into the clinicals or whatever, I mean, you're supposed to get the hepatitis vaccine, and you could have said, yes, I got the hepatitis vaccine, and then they might have said, well, we're going to do a blood test to see if you have antibodies present, because they want to be sure you retained immunity. That's the other question, is how long is the immunity going to last? And for some people, there are some people that do not retain immunity very well, even to vaccines, and some people do. Um, and that's the whole question. I mean, these types of phrases, like immune responses and creation of antibodies and retained immunity, have been in the news a lot lately, because that's the discussion of the coronavirus. Is if you get the infection, will you keep your immune response long enough that if you're exposed another time, you won't get an infection? That the answer to that question is not really known. Or if you do retain immunity, for how long? That's not known either. The coronavirus is a notorious mutator. It is um, it is an animal-borne virus, and we've had this is our third coronavirus mutation that we've had to deal with. The avian flu, the H1N1, that was a viral mutation that occurred. That was a virus that was common in birds that mutated so it could attach to our cells. And that's what the coronavirus did. It's a normal virus in animals that mutated so that it could attach to human cells, and therefore could jump species. So now we have to figure out what to do with it. Um, and that's why we're stuck in this remote learning nonsense. So, anyway, MMR is a live attenuated vaccine, and because it is attenuated, it could cause a subclinical expression of the disease. And it does need a booster. So people that get measles, mumps, rubella vaccine should not get that vaccine if they are immune compromised, because potentially um, they could potentially get measles, mumps, or rubella. Varicella is another example of a live attenuated vaccine, which is the vaccine for chickenpox. If you're immunocompromised, you shouldn't get that one. Hepatitis B is recombinant, but it is made with a yeast medium. So if you're allergic to yeast, you could have an issue. Gardasil, which is the HPV vaccine, is a recombinant vaccine that now only requires 2 doses, which I usually make a plug for the HPV vaccine if you haven't gotten it, to prevent 8 kinds of cancer. So any vaccine, just like we were talking about with the influenza vaccine, has the potential to cause pain and redness at the injection site, because you just triggered the inflammatory process by using a shot, and some kind of viral-like syndrome. It almost feels like a headache, a low-grade fever, muscle and joint pain, and that is because the immune system has been activated. Um, all vaccines have the potential for transient hypotension, which means it's possible that if the patient gets up too fast, they will feel dizzy or faint. And so every now and again, you'll hear a story about somebody that's had immunization that passed out and thinking that that's an adverse effect of the vaccine or that made them ill. It's more that weren't cared for correctly in the office when they received the vaccine. And so this part is usually pretty funny because most people are used to the fact that when we get the influenza vaccine at work, we're all standing in line like a herd. We go through and then you have to go back to work. But the actual rule for getting vaccines is the patient should get the vaccine and sit or lie down in the office for 15 to 30 minutes to ensure they don't have a reaction and that they don't experience that transient hypotension that can occur. So I always think that's funny because that's not obviously how that works when you're at work. But that's how you're supposed to do it. The other issue is that and this can sometimes be on the exam, when you're giving a vaccine in the deltoid, you have to be sure that the vaccine is given in the proper spot because you could inject it accidentally into the tendon where the deltoid muscle inserts into the shoulder. So you want to be sure that you're 2 or 3 finger breaths below that process, the bone that you can feel there, so that you're in the muscle itself. Contraindications: if somebody is immunosuppressed or they're living in a home situation with an immunosuppressed person, they may have to be careful about getting those vaccinations. They may not be able to do them because, especially those live attenuated vaccines, they could get the infection. If the person is very immunosuppressed, they might not even be able to create the antibodies you wanted to begin with. Live vaccines like MMR should be avoided during pregnancy because you don't want the unborn fetus to be infected with whatever the vaccine was. Currently, not all 50 states, but some states allow for exemptions for non-medical reasons, and that occasionally comes up where people try to remove those laws. Wisconsin is a state that allows for non-medical reasons to deny or to decide not to have a vaccine. So that was our active immune medication vaccines. You can passively receive immunity by getting immunoglobulins, which is basically just an IV bag of antibody. The best time to get it is within 24 hours of exposure, but no later than 7 days. So the one that we're talking about is the hepatitis B immunoglobulin therapy. There is no good treatment for hepatitis B. There is treatment for hepatitis C. There are antiviral treatments. They're very expensive, but it can actually cure it. There is no treatment for hepatitis B. So if the person knows they were exposed to hepatitis B and they haven't been vaccinated, then the best thing they can do is be given hepatitis B immunoglobulin just to pretend, almost like pretending they had a vaccine. Like, here, let's try to get rid of it before it takes hold of your body. But you have to give it as fast as possible from the time of exposure, otherwise it won't be effective. So for hepatitis B immunoglobulin, that should be given one time early and then can be repeated in 20 and it should be repeated in 28 to 30 days, and that's often on the exam when you can get the immunoglobulin. Side effects are again just like vaccines because you're giving this immune response, so there can be flu-like symptoms, headache, transient hypotension. There's some extra effects because this is an IV infusion. So there is an allergy, a stronger allergy potential than with regular vaccines, although some people are obviously allergic to vaccines. There's a risk of blood clots, which is what thrombosis means, and a risk of renal toxicity. So we already talked about what renal toxicity is. Oh, sorry, I didn't see your thing, treated. My employer is about to hear it come flu shot season. I need to lay down for 30 minutes in the office. I know, I always think that. Like, we're just like a herd of cattle going through. Get your shot, get back to work. Um, and thrombosis is a clot. So we talked about renal toxicity, reviewing that that's fluid retention, change in weight, and that the patient's B1 and creatinine could be altered. How would you know if somebody threw a clot? So,
Leg
all these
pain.
tests could be, depends on what the clot is, right? Like if they had a clot in their leg, they might have swelling to one leg and pain in their leg. Short of breath. Aisha is talking more about trouble breathing. Kelsey and Aisha on the same page talking about someone throwing a clot to their lung. Redness and warmth could go with Lillian's. Sharita, that's the leg clot. Cough, definitely with the PE, and sometimes blood tinged. Pain, maybe. Could be in the leg or in the chest. What about if they had a stroke? Slurred speech, droopy face, confusion, and then they might have one facial droop. Yep. And usually, so there'll be a facial droop on one side, and then the opposite side. Yes, Brianna's yelling, facial droop! Don't worry about it. Um, yeah, so when someone has a stroke, the nerves that run their face, that'll be on the same side as the stroke. So they might have like if I had a left-sided stroke, I would have left-sided facial droop. But if I had, but that left-sided stroke, what runs the body movement, those nerves cross. So it'll be my right arm and my right leg that might not be able to move or feel numb. Let's see.
Is that
What
why
do you
when
think of?
they
Yeah,
say that left-handed people think with the right sides of their brain, and right-handed
yeah,
people think with the left sides of their brain?
yes, because they do cross. So there's always this speculation that people will have a dominant hemisphere, that either the left or the right are dominant, and it does sometimes tend to match which hand the person uses, but not always. The left side is supposed to be like your language, and the right side is supposed to be more logical and artistic, but I don't know.
I have a question.
Yeah.
Um, you and for the immunoglobulin, did you say that was
Yeah,
more
good.
potent? More potent than the vaccine?
It's just that it's going to be quicker. So,
Okay.
like with the person that gets the vaccine, we have to wait for them to build the immune response. The person who gets immunoglobulin is just getting it right away. And that's our only hope to help the person who's been exposed to something like hepatitis B from actually letting the infection take hold. So it's just really faster. All right. The last immunostimulant is interferon. Sure, sure. So interferon is a messenger, and it helps the immune system work better, and it can help protect other cells from getting infected. So interferon is a cancer treatment, but it also can be used in some viral infection treatments, and it is one of the treatments for hepatitis B. It's just not very good. Like it doesn't ever clear the infection like the medicines that we can use for hepatitis C. it's supposed to decrease or slow down the destruction of the liver. But it has a lot of side effects, GI side effects, those flu like symptoms that we've talked about for all the immunostimulants, headache, low grade fever, muscle joint pain, which will diminish over time but are still present, hair loss. But people can have profound headache and seizures, severe depression with suicidal ideation, and bone marrow suppression are the adverse effects. So it's not without its own trouble. So those are the immune stimulants. Before we talk about immune suppressants, let's take another like little bathroom break or whatever. To 11:25 just to be sure we got the blood flowing before we talk about immunosuppressants. So I eventually will pause this. So 11:25. Let me just resume here. We're going to start talking about immunosuppressants. So the reason you would take an immunosuppressant is because you want to turn off the immune system. And the reason why people would do that is usually because of an organ transplant. We've talked about immunosuppressants that are used for autoimmune diseases, and that's a little bit different. We're trying to slow down part of the immune system, um, and sorry, I got distracted for a second. We're going to slow down part of the immune system to block the continued um, activity of the immune system that's hurting the body. In this situation, immunosuppressants, we're talking about the types that are taken when the person has an organ transplant and we're um, trying to prevent the person from rejecting that new organ. Because even though it's close, or we try to make it close to um, the person's cell types, it will never be perfect, especially in the beginning when they have to be on a very intense regimen of anti-rejection, anti-organ rejection medications. And two of the medicines that are used for anti-organ rejection are medications that we've talked about before. Prednisone and methotrexate again comes up. So anyone on immunosuppressants, especially with these higher doses, should be practicing very good infection control, especially when someone first has an organ transplant, because they really do a lot to prevent rejection in the beginning. And these people will be very vulnerable to potential infection, which would be bad because if someone who is getting anti rejection medications to keep an organ then gets an infection, the only way the infection will go away is if the anti rejection medications are stopped, in which case the person will choose between infection or organ rejection. So it's very bad. So they have to be protected. Obviously, hand washing, avoiding large indoor crowds. We want, when you're in an indoor crowd, you're stuck with all the same circulating air. So it's much, much easier to get an infection if you're in an enclosed space than if you were outside. Avoid, obviously, other people with infections. So if somebody is sick, they shouldn't be visiting you. And that is the reason why you should avoid the very young. So usually, like say a person was on a bone marrow transplant unit where they really knock out the immune system in order to prevent a rejection. They won't even let kids in there. When we used to be able to have visitors, if you were under 12, you couldn't even come visit. Be sure that food is cooked thoroughly and no raw fruits and vegetables so the person doesn't get a foodborne illness. So prednisone, it's always a good time to review prednisone because that's come up before as a medication that is a steroid because it's like our own body's hormone cortisol. that is used to decrease the immune response and decrease and decrease inflammation is what I meant to say. So decrease the immune response and decrease inflammation. And what are some side or adverse effects of prednisone? Because this is definitely going to be on the cumulative exam, prednisone, and now, of course, it'll be on this exam. Weight gain for sure. Yep, increased appetite. There are electrolyte abnormalities that are associated with that, potassium and sodium electrolyte abnormalities. People can have any range between insomnia to anxiety to quick to anger, like Natalie's saying, even to psychosis. Some people's mood is very changed by this. So weakness, nausea, especially if they have some of those electrolyte disturbances you were talking about. Can minimally, it's because cortisol is one of those. Cortisol is a hormone that is near other adrenal hormones, but that's more what you're talking about, Natalie, is spironolactone because it's close to the sex hormones. So prednisone, cortisol, you'll remember the reason that we're taking this medication is to decrease inflammation. So it's a COX-1 and COX-2 inhibitor, and it does decrease stimulus of white blood cell production. So, and it's similar to the stress hormones. So one of the things is that weight gain, it could increase the blood pressure and heart rate because one of the things the stress hormones do is help amplify epinephrine and norepinephrine. Because it's a COX-1 and COX-2 inhibitor, it decreases inflammation, but that's also why it can increase stomach upset and potentially harm the kidneys, like we were talking about, which could also contribute to weight gain and some of those electrolyte abnormalities. It changes mood, it increases blood sugar, it breaks down the bones, causing osteoporosis over the long term, and it can cause cataracts. So it's a lot of stuff. So be sure that you review prednisone again, and it's going to come up again and again because we're going to talk about prednisone again when we talk about respiratory illnesses, because prednisone is part of the treatment of asthma. So it's always going to be there haunting you. The other medication we can use for anti-rejection is cyclosporine, and this in particular inhibits helper T cells. Hopefully not to the extent like we were talking about with HIV, but helper T cells initiate the immune response. So they're going to initiate organ rejection. So if I inhibit their activity, I can decrease the possibility of organ rejection. The most common side effects are retained fluid, decreased urine output, and hypertension. There is always a question about this because look how high that is. There's not many side and adverse effects that have that high of a possibility. It looks like most people are going to develop that. Other side effects: hypertension, gingival hyperplasia. Besides the decreased urine output and hypertension, other adverse effects have to do with liver issues. The decrease in white blood cell count can go so low that the person is more at risk of other types of infections. Thrombocytopenia is a fancy way to say low platelets, and it can put them at risk for lymphomas. Grapefruit juice can increase toxicity, so it's one of those grapefruit juice medications. The other immunosuppressant that we can talk about is methotrexate. So we've talked about methotrexate before. What did we talk about it before? What was it for? Does anyone remember why we talked about the prescription methotrexate? Right. For what disease?
For like rheumatoid arthritis.
Yes, that's correct. So we talked about it with rheumatoid arthritis, and in that time we talked about it as a pill that somebody would take once a week, because we wanted to decrease the autoimmune response, but we didn't want to completely knock out the person's immune system. This, when you're giving it to prevent organ rejection, the patient will probably take a higher dose and end up taking it daily. This works by blocking folic acid, which means the cell can't divide. What was the antibiotic that we talked about that blocked folic acid? Sulf. That's right. It's the sulfa family that is also a folic acid inhibitor. So we so we have to be sure that's a medication interaction. When we were talking about sulfa, it mentioned, when we talked about those sulfa drugs, it mentioned that methotrexate might not be a good addition if they're together. If you are giving somebody this medication, you don't want it to touch your skin, or you don't want to inhale it, because it's actually very easy for it to get into your system. It's a pregnancy category X, which means it is known to cause fetal harm or harm to the mother. It's fetal harm in this case. And it's prolonged, meaning that the person should be on birth control in order to be on this medication, and will need to stay on birth control for 6 months, even after they stopped the medicine. We talked about before that NSAIDs can lead to a bad decrease in white blood cell count, and so ibuprofen and methotrexate should not be combined. Because we're giving this at a higher dose, we could make the patient more at risk for other what are called opportunistic infections, or more at risk for infections, which is why we had those precautions that we said we were going to take. We're not going to, we got to be sure that we don't, put this person in a situation where it's easy for them to get an infection, like an enclosed space, or giving them undercooked meat. And then we have to worry about both of those fatal dermatologic reactions, Stevens-Johnson syndrome and toxic epidermal necrosis, because it could cause both. So that's our immunosuppressants. So the next thing that I was going to do, so we'll just alter the schedule a little bit, is I'm going to open up there's a little math test. Just 3 questions that are very like the questions that will be on the next exam, and it's some of the math questions that tend to trip you guys up when you're calculating rates of bags, like antibiotics or some kind of medication. So there's 3 questions. Answer those, and then we'll go over the answers after lunch. So just answer those 3 simple questions, and then go on your lunch break and come back at 1 o'clock, and we'll start by going over those questions. So I'll see you after lunch.